the topic that is given to me is artificial intelligence in endoscopy, and these will be our learning objectives. It's a big topic, it's a big discussion in itself, and in the next 30 minutes or so we shall try to cover the basic terminology of AI systems for colonic polyp detection and classification, which has been the most developed sub-branch in this area, AI systems for the UGI tract, AI for quality enhancement in endoscopy. In EOS, again it's a very big area, but I'll restrict myself, if time permits, to EOS navigation, anatomical station recognition, differentiation of pancreatobiliary lesions, which concerns this crowd. And in pathology, AI to augment, substitute rows and modes. So I'll see how much I can cover in the next 30 minutes, and then I'll stop wherever my time finishes. So one slide on the nomenclature, so we are all on the same plane. So when we talk of artificial learning, machine learning is a subset of AI. And among machine learning, we can say we have two divisions. One is statistical machine learning, which has linear regression, decision tree, k-means. So basically, statistical machine learning helps you to classify. Say a Gmail classifies my mail as spam. That is a statistical machine learning. On the website, you want to buy a house, and based on the multiple parameters, the website tells you that, look, this is the likely or the best price for that house. That is a regression. When we talk of deep learning, we are dealing with artificial neural networks, and the subtypes of deep learning will be convolutional neural networks, with which we shall be dealing most often in endoscopy. When we talk of convolutional neural networks, this is a particular subtype of stacked artificial neurons, and they are very well suited to deal with unstructured data like we have in images and videos. So very briefly, what happens is, when we feed a convoluted neural network an image, there is something called filters, and these are very small filters, 3x2. So each pixel is sort of interrogated by a set of filters, and the filter moves over the image, and each filter is designed to pick up one pattern, say a linear, a circle, a dot, and so on and so forth. So multiple filters move over each layer, and then the data from each layer of CNN is transferred to the next layer. So first layers of CNN will take up these simple patterns, and then deeper layers will then assimilate these simple pattern into more complex shapes. This is important because in an image you can have polyp in the right upper quadrant, left upper quadrant, different halation at an angle. So the CNN can actually teach itself how to interpret an image. Then we have recurrent neural networks, and we have something called transformers, which is the basis of the agentic and generative AI. Besides machine learning, AI is also there in regular expression or regex, rule-based systems and robotics, and we will not discuss all of this. So this is how AI applies to the GI tract. In the esophagus, for the detection of Barrett's esophagus, squamous cell carcinoma, burn, or Barrett esophageal related neoplasia. In the stomach, for diagnosis of H. pylori, early gastric cancer. In the small bowel, the AI can interpret your capsule endoscopy studies. Most developed in the large bowel, and we'll begin with this by the detection and diagnosis of colonic polyp, the inflammatory bowel disease activity assessment, and very important for our hospital, the quality. The mucosal exposure in the upper GI tract, in the lower GI tract, monitoring bowel blind spots, bowel preparation and colonoscopy, procedure timing, photo documentation, and we shall cover some of these as we go ahead. So the two basic terms that we encounter when we talk of AI is CAD-E and CAD-X. These are generalizable terms to different platform. CAD-E is computer-aided detection, and CAD-X is computer-aided diagnosis. So if I talk of colonoscopy, CAD-E or detection is triggered once you have washed the mucosa and you are withdrawing the colonoscope. And CAD-X will characterize whatever you detect after you detect it. The main function of CAD-E is localization, also called segmentation, and I'll show you. And CAD-X will give you something like a optical biopsy. It will characterize the histology in real time. The input for CAD-E is mostly white light endoscopy, sometimes LCI, but for CAD-X we will often need enhanced imaging to characterize, sometimes magnification. Applications for detection are detection polyps in the colon, burns are Barrett esophageal related neoplasia, esophageal squamous cell carcinoma, and early gastric cancer. This is where this technology is shining, and I'll show you. And CAD-X will classify these abnormal areas. It will tell you whether the burn is dysplastic or non-dysplastic, what is the depth of squamous cell carcinoma, and so on. So these are two images from our department. I'm doing a colonoscopy here, and the CAD-E has placed a blue box over a subtle polyp that it has picked up. So this is the system has detected a subtle abnormality. You can see my cursor, and this is a small polyp. This is an example of CAD-X, and this is a Fujifilm system we have in the department. So this actually diagnoses or characterizes it. It's an optical biopsy. So the green outer ring tells you that it is a hyperplastic polyp, and this is a map which shows you where the lesion is, which it is characterizing. So this corresponds to this in the position map. This is called a position map. So let's begin with the colonic polyp detection and identification, which is the most developed area. And first, why? This is because when we talk of colorectal cancer, it is the third most common cancer in incidence globally, and second highest in the overall mortality among the cancers. The rationale for using AI in colorectal cancer is the following. This is based on a landmark paper by Corley in NEGM 2014, and I'll request all of you to read it, where he showed that for every 1% increase in adenoma detection rate, or ADR, there was a reduction in interval colorectal cancer by 3% and mortality rate by 5%. Now, SSL or sessile serrated lesions or sessile serrated adenomas are becoming very important, and a recent paper showed that for every 1% increase in SSL detection, which are actually very difficult to detect, is associated with a 7% decrease in interval colorectal cancer. Plus, we are not very good at colonoscopy. There is a substantial miss rate, and this was a multi-center Chinese study, is often quoted, and the missed polyp detection rates are 27%, mostly small polyps. So over a quarter of polyps will be missed even by a good endoscopist, even with good bowel preparation, and this will depend on so many factors. So we need something to improve our colonoscopies. So this is in a nutshell the pipeline for building an AI polyp detection, that is CAD-E, and characterization, that is CAD-X system. So we feed the algorithm input images, and I'll show you the databases from which these are taken. And then these images are pre-processed. You size the image in a standard size, you do color correction, you label them, you crop them, and you sort of balance the colors in the different images. Then the next step is image augmentation. So augmentation is required because the data sets are limited. And then in practice, if you are approaching a polyp, you can approach it like this, like this, like this, with at different distances and with different illumination. So the same images in the case of augmentation are used to generate multiple images by rotation, flipping, random crops, which sort of mimics you going closer to the polyp. So all of these are done to augment your existing images, so that say n number of images becomes nx number of images. Then we train the model, and for training we do something called segmentation, detection and classification, and then there are something called training basis on which the algorithm is trained, and tuning basis on which it fine tunes, and then we evaluate. This is called validation, and this is usually, it should be done on an independent data set, and the purpose of validation is to avoid overfitting. Overfitting of an AI model means that it will do very well on the training database, but when you expose it to an independent real world scenario, it will sort of falter. That is called overfitting. Hence we need to train or validate a data set before we launch it into public domain. Now these are the segmentation methods. So DL means deep learning. So the deep learning model will localize a polyp and using predefined masks. And for those of you who have ever used something like Adobe Photoshop, you will know what a mask is. So you mask a area in Adobe Photoshop and take off the sort of make it vanish. In the newer iPhones, Samsung phones, you can do it with your finger. You can see in your picture some person you want to take off. So you can segment that area and you can actually, the AI can take it off. So that is called a masking. And common segmentation methods are UNet, and we'll keep talking of UNet. This is a CNN platform. SegNet and fully convolutional network, or FCN. These are the common segmentation masks. Other polyp detection methods are by drawing bounding boxes, heat maps, or other overlays. So what the system is doing, it is giving you 4 coordinates, 1, 2, 3, 4. So it basically detects the coordinates where it is seeing an object and draws a bounding box in real time over the detected objects. And now with the current technology, this can be done in real time. So you can continue to do your colonoscopy and at 60 to 30 to 60 frames per second, near instantaneous detection by the system. GI Genius is a Medtronic platform. It can detect polyps with more than 95% sensitivity in real time. And the architecture for polyp detections are RCCN, recurrent convolutional neural network, faster RCCN, SSD, and YOLO. YOLO is you only look once. And YOLO is the platform which most of the current commercial systems are using, and we have version 2, 3, 4, and 5 for YOLO. This is just to show you an example from the Pentax system. This is called Discovery, and it has placed a blue bounding box. Much of the work which I will quote is from China, and you can see red boxes around the polyps. The logic of this is that you can do it in real time and you do not obscure the image by highlighting it in this way, unlike a segmentation where you mask it. So bounding boxes are what we use because you can continue to see what the system is pointing out to you. Now once you have detected, you want to classify. This is called CAD-X. And we use pre-trained models based on the principle of transfer learning. Transfer learning means that you have taught the model on certain data sets and you transfer the intelligence or learning from that data set to the real world scenario. So this is the principle of transfer learning. And for these you have pre-trained CNN models. So what we have in ILBS in our department is a pre-trained model. It is already trained. We are not training it. So it is based on transfer learning. And what we have is VGG16, VGG18. These are very common platform. These have very small filters, so can detect small abnormalities. ResNet50, this is a classification algorithm, very commonly used. This is a recurrent neural network. Exception, LXNet, not commonly used, and YOLO. So YOLO is, you'll hear more and more because it can both detect as well as classify the abnormalities that it's seen. And the classification algorithms of the current platforms are 85 to 95%, very close to the expert level. These are the benchmark, just an examples of the recent benchmark colonoscopy data sets on which the commercial platforms have been trained, and these have both static images and videos. Now let's go to, after all the mundane didactic discussion, let's go to some practical applications. This is the system that we have in ILBS. This is the expansion unit EX1, and it is a CAD-I system from Fujifilm. And what it shows you on white light and on LCI, it will detect. So this is a detection box, and this is a visual assist circle which also tells you which quadrant it is seeing. Then on BLI or blue light imaging, it will tell you the status bar, how confident it is in diagnosing. A visual assist circle by the color of which you can decide what it is, a position map and a characterization results. And CAD-I system does it at 60 frames per second, so it is very good in real time. There are certain obviously technical things which you have to do to maximize the output. I will not go into this, but basically you have to feed the algorithm a clear image of the polyp and with pre-specified structure and color emphasis on your system. So the resident should know this, but I'll skip this. We also have in the department the Olympus CAD system called EndoAid CAD-E, the OIP1 box. It is lying here. And this is the normal mode where it will show you with bounding box the polyp on one side and on this single image. So we have both these systems. This is just to show you one of the colonoscopies I am doing. So it is detecting this polyp, and this is BLI or blue light imaging, and in the position map it is color coding it as yellow. So the system is already deciding that it is adenomatous. Even before I have made up my mind by looking at the villi and gyre pattern on it, it is telling me that look, it's likely a adenoma. And this is the level of confidence: 1 bar, 2 bar, 3 bar. If there are 3 or 4 bars, I am happy and I'll believe the CAD X. So you see it is picking this up, and it is telling me that it is a adenomatous polyp. We are resecting it. Histology proved that it is a adenomatous polyp. Then in the same patient, it has picked up another polyp, looks different, and now it is telling me that this polyp is actually a hyperplastic polyp. So I resected it, but I could have just diagnosed and leave it. So it helps you guide the it acts as a second pair of eyes in the endoscopy room. So the principle is that if I am doing a colonoscopy, this is an assistant, another expert is standing by my side, and now 2 people are looking at the same colonoscopy. So these are called the second pair of eyes for colonoscopy. This is just a forest plot, a new latest meta-analysis which shows you the AI used for reducing adenoma miss rate. See that the 95% CIs don't straddle the 1 for the odds ratio, and the odds ratio is 0.34, which shows that it is very good to reduce adenoma miss rate. Let's talk of the upper GI tract. Most data on upper GI tract for esophageal squamous cell is from the east, from Barrett's is from the west. The rationale for using AI. The rationale is that in the upper GI, as all of you would have seen, the cancers are much more subtle, the dysplasias are much more subtle, and the miss rate world over is 5 to 25% in the esophagus and the stomach. And when we talk of Barrett's neoplasia, it is even more difficult because most of these are 2A or 2B lesions, Paris classification, with a 20 to 40% miss rate of visible neoplastic lesion. Hence the Seattle protocol, which tells you that you must take random biopsies to pick up invisible dysplasia. But for me, nothing is invisible with the current era of technology. So this is again a detection mode from the Fujifilm. They have launched it, and I'll show you how it does. So we pass the endoscope, and I'll show you more images. This is schematic, and just look at how beautifully it is detecting something we may have missed, something here. So if you look, it has extremely good eyesight, and now we are in the stomach, schematic, and just look where it is placing the bounding box. It is highlighting that look here, something is wrong here. It is drawing your attention here at the peripheral visual fields. So if I am tired, if I have done many cases, I may miss these, but so this is acting as a second set of eyes behind me, pointing out these very subtle lesions which we may otherwise overlook in routine endoscopy. Obviously you have to prepare the mucosa and so many other things. Just to show you how difficult it is to pick up a burn or Barrett's esophageal related neoplasia. I don't know if you can appreciate, a bounding box has highlighted a neoplasia here. This is better seen, a neoplasia here. It is a small 2C lesion and another neoplasia here. But this only highlights how easy it is to miss a neoplasia in the esophagus. Now, Prateek Sharma recently published in Gastroenterology a pooled data from 9 studies, and these are the sensitivity, specificity for picking up burns, and a very good negative predicting value. I shall just show you a example. See that it is giving me a overlay heat map, and this is red. So it is telling me that this is dysplastic, this is green. So it is telling me don't bother here, this is non-dysplastic. So obviously I know it is Barrett's, but now it is giving me a stable prediction. There is a definition for this. It is highlighting that look, this is a dysplastic area. This is a dysplastic segment in Barrett's. This is a dysplastic segment in the Barrett's. It is giving me a color segmentation mask, a transparent segmentation mask. So dysplasia, non-dysplasia. So now I know how much disease there is, and this really helps, particularly in Barrett's. Now for gastric adenocarcinoma, most studies have actually come from China, mainly Wuhan University and Nanjing, and also Xingzai. And this was another publication by Pratik Sharma, again pooled data from 7, and even in the stomach, where as endoscopists we miss so many lesions, it shines, and I'll show you. This is the Endo Angel developed by Wuhan University. And when it detects something benign, it gives blue, but now it has said that, look, it is neoplastic. So it is telling me a red bounding box. It is also predicting the invasion depth. It is telling us that based on the surface pattern, it has some mucosal invasion. So this is how sophisticated we have become. Now we have turned out the NBI, and look, this is a simple scope, 190 scope. It is telling you that it is unable to characterize the cancer, so you persist. It is unable to characterize, so you persist. You try to focus, you try to wash the same cancer, and finally it tells you that it is an undifferentiated cancer. So not only has this system, this algorithm picked up a early gastric cancer, it has told you that the depth of invasion is submucosal. Go ahead, do an endoscopic ESD, but then it is undifferentiated, so well, not a very good candidate. So that is the kind of sophistication. Here is another example, again from Endo Angel. See what it is picking up. Again flagging it as neoplastic, red box, and invasion depth was mucosa. It is a superficial cancer, and it also tells you it's a differentiated cancer. So this is a real-time virtual optical biopsies, and this is the kind place where AI has taken us now. This is the model developed by the Nanjing University. Some of these are commercial. Endo Angel has been marketed. I'll show you. So see what it is flagging, and just think in your mind, when you are doing endoscopy, would you have missed this lesion? Again, the upper right, picking up a cancer here. In the cardia, picking up a cancer here, very subtle redness. And in this stomach, on this side, it is flagging abnormal area, something at least I may have actually overlooked. So this is the kind of sophistication we should be aiming for going forward. So, but for this house, what is very important is AI in endoscopy quality measures, how we can improve, since we deal with fellows here. So again, Fujifilm has launched this landmark photo checker, and there have been 6 installations in India, including Kokilaban, Fortis Jaipur, and 4 other places. They have already purchased it. So this basically tells you how much of the stomach you have evaluated. So the first step is that you don't do a cursory upper GI. If you have missed an area in the stomach, it will flag you, and I'll show you how. So look at this image. So it is, once you retroflex, the machine is seeing what you are doing, and it will continue to flag in real. And now you have to make the whole stomach green. It is like a video game, so that we know that the fellow or the faculty has completely evaluated all the areas of the stomach, has not missed area. And Dr. Mahesh Goenka actually did, with the previous version of this, actually did a study on this from Calcutta and presented it. So this is very beautiful, can be a source of many studies. For colonoscopy, all of you have seen that the bowel preparation is often the HLA seal. You have a lot of stool. So we need objective methods to automate bowel preparation assessment, and there are many methods. We use BBPS in our department, that is Boston Bowel Preparation Score, and every colonoscopy report I insist you give a BBPS score. And now the AI can automate it. So it will tell you in a scale of artificial scale of 0 to 20, it classifies BBPS 0 and 1 in 1 and 2 and 3 in 1. So 0 and 1 is bad and 2 and 3 are good. And so it will flag the areas, the percentage of areas which are not good. And this is the cumulative ratio. So it actually tells you more objectively and a more refined way how much of the colon and which part of the colon in real time has been adequately prepared. So it is flagging that the transverse colon 75% area is obscured, and this can actually have a lot of consequences. The patient can also utilize AI by this AI driven smartphone app, and in this study 544 patients were randomized for their colonoscopies into standard preparation and AI app on their smartphone driven preparation. So after the patient prepared their bowel preparation, they snapped a picture in the toilet bowel of the kind of stool that they had passed last when they felt they had prepared. And then the colonoscopist graded the preparation in endoscopy on BBPS, and this data was used to train the model. And subsequently, they have then validated it, and this reinforces the patient, and this actually helps in better bowel preparation. Colonoscopy withdrawal is another very important thing. The defined or the minimum time for colonoscopy withdrawal is supposed to be 6 minutes, and no faster than 6 minutes from cecum back out through the anal canal. And if you withdraw faster, you will lead to adenoma miss rate. So AI can monitor the withdrawal time and warn when endoscopic slipping occurs. There is also something called effective withdrawal time. So you may be withdrawing very slow, but you may be sleeping, and you may not be looking, and you often have a red out when you are withdrawing. So what is called effective withdrawal time, when you actually see what you are seeing when you are withdrawing, and also fold examination quality. So this tells you, if you look here, this is a poor fold examination. You are getting red here. So you are withdrawing, but you are not actually seeing anything. When you withdraw, you should center the colonoscope in the lumen and then withdraw. So this helps. I'll rush through since my time is coming. And this is very exciting for me. This is a paper by Thakur in Gastroenterology 2020, and this is the kind of endoscopy fingerprint or endoscopy report additional that we should be striving for. And this gives you a multi-parametric assessment of the endoscopic quality. So each of these length is 5 centimeter segment of the colon as you withdraw. This is the top left, top right, bottom left, bottom right, and this is the aggregate percentage of mucosa that you have seen for every 5 centimeter that you withdraw. 100% visualization here, 87% here, 42% here. And this also sort of tabulates in real time the clarity, the preparation of bowel and the distension, whether you have adequately distended the colon or not. So after any colonoscopy is done, this kind of a report should be appended to the patient, and this is how the future is going to be, that how much of the mucosa you have seen, whether the clarity was good, the preparation was good, the distension was good, and this can be routinely appended to our colonoscopy reports going forward in the future. Now, Satinder, can I take 2 more minutes? 2 minutes. So it's 9:28. I have 2 minutes. I'll request for 2 more minutes. So for EUS, I'll just rush through. This is will not of interest to many people. So basically, you have the iRead framework, which are actually multiple DCCN. So initially, you have a classifier DCCN1, which classifies where your endoscope is. This is a ResNet architecture. And then you have a nested unit or a unit plus, which actually segments the pancreas, the bowel, the bile duct, and blah blah. So this is, I'll just show you how sophisticated this has become. So you have to see all these stations. So it is segmentation. This is segmentation. It is segmenting the pancreas with the green. It is segmenting it is telling you it is kidney. It is segmenting the vessels in red in real time. And this is very useful for the trainee. I don't have time. I'll rush through. And this is commercially marketed by the EndoAngel system. This is a recent paper by Rizzati from kidney, and I was talking to the French endoscopists recently. They have widely adopting EndoAngel in the French centers also. For pancreatobiliary lesion, just to show you, this was a multinational study, and see how beautifully things have become. This was from 4 international centers. A big trouble is mucinous versus non-mucinous pancreatic cystic lesions, 99% accuracy. I can never match this system. 94% accuracy for pancreatic ductal adenocarcinoma and neuroendocrine. And what is very troublesome for us is cystic lesion characterization. So this paper by Vilas Boas, this is the strength of recommendation. And most of the recommendations it made was correct. So it could characterize the cystic pancreatic lesion looking at subtle features which we don't recognize as EUS people. This is very exciting. This is a joint artificial model. So when we do EUS, we are looking at the clinical data and the EUS data. We are not looking at EUS in random. And this is the first model which actually takes 2 branches. One is the image branch. So here is a carcinoma with pancreatic duct obstruction, and it is now telling you probability of being carcinoma, 99% based on image. And not only that, it is placing these heat maps which tell you where it was looking when it decided that, look, this was a carcinoma. Then this is a clinical branch, where it is looking at 36 features, and it is also giving you a SHAP, or a shapely additive predictor here, which tells you which feature it was looking at when it decided that this was carcinoma. So the imaging branch and the clinical branch merged at a multi-layered perceptron, and then it gives you the joint AI model of 99% probability of being a cancer based on imaging and clinical features. So this is beautiful. I am 1 minute up. I'll just finish. These are my last 3 slides. So pathology, AI is getting extremely exciting. So now after training a simple DCCN, it can segment, it can highlight which area it is looking, and it will tell you malignancy or not, at least for PDCA with 95% accuracy. This is just to show you the Chinese work, how simple it is. This is a segmentation mask, and by the degree of segmentation, it tells you the sample is adequate or not, and then it tells you cancer or not. So we just stain on site as we normally do in our endoscopy, and this system was as good as a endoscopist trained for 6 months in pathology or a expert cytopathologist. So it is already matching that. We can also evaluate FNB material for adequacy. I don't have time for this. This is last slide which I shall dwell on. Hyperspectral cytology imaging. So normally when we image a slide after staining with HNB, we are looking at certain spectral bands, RGB, red, green, blue. But we can also measure each spectral band, which means continuous spectra from 450 to 750 nanometer with a simple microscope mounted machine. And now with this machine, the spatial coordinates are given in Y and X, and each spectrum is stacked behind the RGB image as a hyperspectral cube or a hyperspectral stack. The logic is that as the tissue changes in composition, as cancer comes up, there are small changes in the molecular structure of these cells, and the spectral signature of these cells differ. So very useful in borderline cancer cases and certain other situations. So such a simple concept. We are doing nothing. We are doing the usual H&E, and this is a machine which is always available. You construct a hyperspectral cube, and now you let the AI decide which band it wants to pick and what it wants to predict. So I'll summarize that AI is intended to facilitate and not replace the endoscopist. By automating detection, that is CAD-E, and diagnosis, that is CAD-X, AI is improving the accuracy and efficiency of endoscopy, as I showed you. AI models can benefit trainees, early career endoscopists, and others. The main goal is that it will mitigate the quality differences between inter-individuals. However, it can also lead to cognitive overload. There is so much thing going on my colonoscopy or EUS screen. Thank you.